Good evening, students. Good evening, students. So we are here for the PYQ based session for INICET May 2025. Please confirm if the audio and video is fine. Please let me know in the comment section. So in today's session, we'll be covering a few PYQs from INICET. So your exam is scheduled for the 17th of this month. All right. So basically the syllabus remains the same for INICET. However, the questions tend to be a little different. Recently there has been also a trend of multiple answer questions, image based questions, and a few clinical questions. So along with the questions, we'll be just discussing a few topics associated with the questions also. And yeah, so let's start. We start with question number 1. Which rib is the most preferred for harvesting costochondral graft? Good evening, Junaid. Good evening, Junaid. Okay, so option A is 2, option B is 4, option C is 6, and option D is 10. So all of you can let me know your answers in the comment section. All right, please write the question number along with the answer, and we will revise a few points or topics related to the questions after we come to the answer. All right, so please quickly let me know the answer in the comment section. Okay, do we have more answers? Okay, any more answers? So the correct answer here is option C, that is 6th rib. Okay, we will quickly revise a few points regarding your costochondral grafting, which in very simple terms is nothing but your rib grafting. All right, rib grafting. So when we say costochondral, it means bony plus cartilage part, and this cartilage part is the growth center. Okay, so it is the most commonly used technique for TMJ reconstruction. It was first described by Gillies and was advocated by Caban. Graft, I just now told you, it contains bone plus cartilage. Size of the cartilage portion was taken as 2 to 4 mm as per the Caban's protocols in 1990. Okay, when he revised his own protocols in 2009, he said that the cartilage portion should be in between 1 to 2 mm. Right? Why? Because of high chance of variable growth. All right. What do we mean by high chance of variable growth? It was seen that the site where the growth center was transplanted was overgrowing, all right, as compared to the normal side. That is why it was decided to reduce the portion of the cartilaginous part so that we can keep its growth under control. However, it still does show properties of variable growth in patients, all right. Now, the next important point is on which this question was based. Fifth, sixth, and seventh rib can be taken for grafting. Okay. Fifth and sixth is preferred in males, and sixth and seventh in females. So the common rib which can be harvested for both the genders is rib number 6. All right, and sixth and seventh rib is taken for females to hide scar in inframammary crease. So this was the question point, the point that gave us the answer to the question that we just discussed. And contralateral rib is preferred because of good contour. So if you are doing the reconstruction example, if you're doing the reconstruction of, let's say, left TMJ, you will always use a right costochondral graft, all right, because of its better contour. Now, the complication that can occur while harvesting this graft is a pleural puncture. Okay. So, how do we rule out a pleural puncture? Once you harvest the graft, you irrigate the chest wound with saline to look for any air bubbles. If there are air bubbles present, that means there has been a breach in the pleura. All right. And another important question is, rib cutter is used to harvest the costochondral graft. Okay. So these are few important things that you need to remember in regards to costochondral graft. All right. Coming to the next question. A patient comes after road traffic accident having displaced mandibular parasymphysis linear fracture. For closed reduction treatment in this case, what should be the ideal duration of IMF? So your options are option A 2 weeks, option B 4 weeks, option C 8 weeks, and option D 12 weeks. Okay, please let me know your answers in the comments. Good evening, Shivai. I do have a couple of image-based questions here in this session as well. But I would recommend that you please go through previous year's image-based questions also for INICET, and you can also go through the visuals that we have provided you throughout the year, because there is, in the last few exams, there have been a couple of image-based questions from all subjects. So it is better that you revise your images from wherever possible and then go for the exam. All right, is that clear, Shivai? Okay, so the answer to this question, more answers. Yes, very good, keep answering. Okay, so the answer here is option B, 4 weeks. Alright, we'll quickly revise the rules for IMF. I have taken this almost in every session in the class. Thank you, Shivai. Thank you so much for your kind words. Intermaxillary fixation rules we all tend to forget. That's why I have made it a point to discuss it in every or almost every session wherever it is possible. So there are certain rules for intermaxillary fixation. We'll quickly revise so that you can remember. So the baseline, please always remember the baseline that you have to remember is a young adult with fracture of angle receiving early treatment in which tooth is removed from fracture line. It is 3 weeks of immobilization. This is something that you have to remember. This is the baseline. Whatever subtractions or additions we do to 3 weeks. Alright. Now, if a tooth is retained in fracture line, you add another week. Alright. Fracture at the symphysis, you add another week. If a patient is above the age of 40 years, you add another week or 2 weeks. Now here let us see when do we add 1 week or 2 weeks. So if the patient is between 40 to 50 years of age and there are no systemic conditions, you can add 1 week. But if the patient is between 40 to 50 years with systemic conditions, you will add 2 weeks. Alright. Or if the patient is above the age of 50 with or without systemic conditions, you will add 2 weeks. Now why is it so? Because with increase in age, the regenerative capacity or the repairing ability of the body decreases. Alright. So that is why. So I hope this confusion between 1 and 2 weeks would be sorted and you all will remember in the exam. And if you have to do IMF for a child, you can subtract a week or minus a week. Alright. So now let's go back to our question. The question has really not mentioned anything for us. It has only mentioned that a road traffic accident patient having displaced mandibular parasymphysis linear fracture, and they're asking specifically closed reduction. Ideally for a displaced fracture we are going to do ORIF, but here when they're asking you in terms of closed reduction, you will answer accordingly. So we saw that for a symphysis or parasymphysis fracture, we are going to add another week to 3 weeks. So 3 plus 1, the answer is 4 weeks. Okay. Good evening, Monirudya. 8 weeks usually we do not do IMF, and some places the answer might be wrong in some of the question banks. You can correct that. Okay, Monirudya. Thank you, Junaid. Thank you so much for your kind words. I'm really happy to have made a difference and to have helped all of you throughout the year. And thank you so much for your appreciation. Okay. Now let's come to the next question. Question number 3. In order to prevent heterotrophic bone formation after osteoarthrectomy, which of the following should be used? A. Cartilage grafting. B. Fat grafting. C. Muscle grafting. D. Gap arthroplasty. So please answer this question and focus on, it says prevent heterotrophic bone formation. So I'm waiting for your answers in the comment section. More answers? Everyone, please answer in the comment section. Don't worry even if you get your answers wrong. This is not INI. This is just your revision session. So yes, all of you have got this correct. The answer is fat crafting. Now, when we talk of fat crafting, we specifically talk of buccal fat pad crafting. Okay. So this is the best technique, buccal fat pad grafting. It is soft, fluidic, fatty tissue which can be mobilized easily. It is near to the surgical site. It has minimal morbidities, and the most important thing is it prevents heterotrophic bone formation. Heterotrophic bone formation is basically bone formation in soft tissues. Now why this point is important, I have explained this in class also to everyone, that when it was seen that even after using various interpositional materials, in few cases in patients still reankylosis was occurring in spite of using a glenoid fossa lining material or in spite of using an interpositional material. So the advantage of buccal fat pad lies over here, that when you use that as a interpositional material or glenoid fossa lining material, it prevents its own calcification or it prevents bone formation in buccal fat pad tissue. So that is one major advantage and property of buccal fat pad, which is very advantageous to us. And here when we say of prevention, this is prevention of heterotrophic bone formation. So how do you prevent that? Long-term NSAIDs, bisphosphonates, and radiation therapy. And in NSAIDs also indomethacin. Okay, this prevents heterotrophic bone formation, and this has no disadvantage. Buccal fat pad use has no disadvantage. That's why it's the best material. Okay. Coming to question number 4, all of the following can be seen in bilateral fracture of condyle except open bite, drooling, deviation of chin, and pain in preauricular region. So this is a question where multiple options are correct. So please read carefully and answer. Please remember, when you're answering such questions, always rule out. Read your option one by one, correlated with what is being asked, and then figure out whether it's true or if it's false. That is the way to answer this question, such kind of questions. Yes, so the correct answer is C. Now, let me just explain. So it's asking, basically it's asking you about features of bilateral fracture of condyle. So do you see a open bite in bilateral fracture of condyle? Yes. Do we see drooling? Yes, because of open bite, there is going to be drooling because of the patient's inability to close his or her mouth. Deviation of chin? No, this is seen in unilateral condylar fractures. Alright. And pain in the preauricular region? Yes. On both the sides or on one side, but yes, it is going to be present. So option C is the correct answer. Now, bilateral condylar fractures. Please remember, this kind of fracture is the only fracture which has true anterior open bite. There is no facial asymmetry, so no chin deviation. Drooling of saliva. And along with true anterior open bite, you can also remember bilateral posterior gagging of occlusion. Alright, because bilateral teeth, due to bilateral condylar fracture, what will happen? Posterior ramal height will shorten. Alright, due to which there will be premature contact in the posteriors and which will result in an anterior open bite. Okay. Let's come on to our next question. This was asked in November session, November 2024 session, this question. I have added it again over here because this is a postgraduate topic and you people will tend to forget it. So coming to question number 5, it says Manson's subunit principles is applied for which of the following fracture management? Option A, comminuted zygoma fracture, B, comminuted NOE fracture, C, dentoalveolar fracture, and D, panfacial fracture. So what would be your answer? More answers? So the correct answer is D, panfacial fractures. Now, whenever there is a panfacial fracture, it means that almost the entire facial skeleton is involved, or almost every bone in the facial skeleton is fractured. Okay, so this is also known as multiple fractures, multiple site fractures in the face. Now, when you are restoring such fractures, there's distortion of gross anatomy. All right, when you're restoring such fractures, your aim is to always restore the width. Width is determined by your bizygomatic width, so facial width. Projection, that is in this dimension, projection of the face. And finally, the height, this height of the face. You restore in this particular fashion: width, projection, and height. These are the things that you take care of. Now, Manson was a clinician who gave us the sequence of restoring panfacial fractures in his article, and he came up with two sequences. He said either you can go bottom up, inside out, top down, outside in. Okay, so let us see for the first one, bottom up, inside out. Repair palatal fracture first, followed by securing IMF, followed by repairing mandible fractures, maybe symphysis, body, angle, whatever, followed by repairing condylar fracture, followed by repairing frontal sinuses, then naso-orbitoethmoid complex, followed by repairing the zygomatic complex and arches, and last you repair the maxilla or end at leaf foot levels, and the last you actually do is leaf foot 1. So this is one sequence. The other one is top down, outside in. So you start from the top, that is your frontal sinus, repair of zygomatic complex and arches, the NOE complex, this is repair, a typing mistake, repair of leaf foot and mid-palatal split, securing the patient in maxillomandibular fixation, and finally repairing the mandible and condyles. Alright, now no two sequences are superior to each other. They have equally good results. It entirely depends on surgeon preference. But you will have to remember the sequence because there can be questions which can be asked on sequencing. Alright. So the next question that I have is on this sequence. It says, in panfacial fracture, what sequence will you follow for reduction of the following bones? 1 palatal, 2 zygoma, 3 mandible, and 4 maxilla. Please read carefully. You can go back to the sequence and then answer so that you can remember a bit of the sequence as well. All of you, please try to answer this question. You can refer to the sequence above. Yes, very good, Nikesh. Others? Okay. So the correct answer here is option A. Palette. Is this ink visible to you all? I use a darker ink. Palette followed by mandible followed by zygoma followed by maxilla. Okay, I'll again go back to the sequence so that you people can revise. So this is bottom up, inside out. It says we repair the palate first, followed by IMF or MMF, followed by mandible and condyles, followed by frontal sinus, NOE complex, the zygomatic complex, and finally we end at leaf foot levels or at maxilla. So this is your sequence. Bottom up, inside out. Okay. Now another important thing related to this particular question and which can be asked. So just quickly revising the horizontal and vertical buttresses of the facial skeleton. So your horizontal buttress includes the frontal bar. Okay. It includes the infraorbital rim. It includes the hard palate. And it includes the horizontal mandible. So these are your horizontal buttresses, which I've marked in pink. Now coming to the vertical buttress, nasomaxillary buttress, zygomaticomaxillary buttress, the zygoma and the maxilla combined. The pterygomaxillary buttress. So the pterygomaxillary buttress you actually can't appreciate in this figure because it is where the pterygoid plates are. So that horizontal aspect on the inside, okay, that horizontal aspect, that area of the pterygoid plates is your pterygomaxillary buttress. Okay, and fourth is the vertical mandible. Fine. And please remember, we do not plate the pterygomaxillary buttress. No plating because it is inaccessible. Okay, these are important points. Now let's come to question number 7. In pediatric patients in comparison to adults, all of these are reasons for increased chances of TMJ ankylosis except A. Bulbous condylar head with increased marrow content, B. High osteogenic potential, C. Increased lateral pterygoid traction, and D. Short neck of mandibular condyle. I'd like to know the answers to this question. Question number 7. Others also please answer. Okay, so the answer here is increased lateral pterygoid traction. This is not responsible for ankylosis. Alright, this is not responsible for ankylosis. Quickly, let's just look at the burst theory. Okay, now I'm going to draw a condylar anatomy of child and an adult. So this is the glenoid fossa and this is the glenoid fossa. So what is happening over here? Absence of condylar neck. So the child does not have a thin, narrow condylar neck. Fine. So whenever there are forces, whenever there is an impact, what happens is that the condylar head fractures into multiple small bony fragments. Head fractures or bursts into multiple small bony fragments. Now, since it's a child, these individual bony fragments will have high osteogenic potential. Okay, and because there has been a fracture, there would be bleeding into the joint. So what will happen? Organization of blood clot. This increases risk of this highly increases risk of ankylosis in children. Why? Because this is a intracapsular fracture. When I say intracapsular fracture, that means within the TM joint. Whatever structures are involved. Glenoid fossa is an intracapsular structure, disc is an intracapsular structure, condylar head is an intracapsular structure. So the part or the components which are involved in formation of joint are known as intracapsular structures. Okay. Now what is happening in adults? There is a thin, narrow, weak condylar neck, and this prevents condylar head fracture and acts as a safety mechanism. So even if you'll just remember this much, this diagram, so if the question is asked in different format, if it's twisted also, you will be able to answer. So these are just 2, 3, 4 points that you need to remember, and you'll be able to answer such kind of questions very well. Okay. Now let's come to the next question. Which of the following techniques can be used for reduction of zygomatic complex fracture? 1. Gillies temporal approach. 2. Submandibular approach. 3. Dingman or lateral brow approach. 4. Preauricular approach. 5. Maxillary vestibular approach. And 6. Carrel-Gerard T-bar screw approach. So what would be the answer here to question number 8? Please answer, all of you. I want you to answer. This is a multiple option question. Multiple correct option question. Okay, shall we see this question one by one? Which of the following techniques can be used for reduction of zygomatic complex fractures? So first option says Gillies temporal approach. Yes, this is used especially for zygomatic arch fractures. Submandibular approach, no, this is used for mandibular body fractures mostly. Dingman's approach, yes, this is used to address the frontozygomatic suture region over here. Preauricular approach is for condylar fractures or TMJ surgeries. The next one, maxillary vestibular approach. Yes, this is used to access the zygomatico-maxillary buttress region intraorally. And Carrel-Gerard screw is used to, if there is a depressed zygoma fracture, the Carrel-Gerard screw is engaged into the zygoma bone, and it is used to reduce or lift out or restore the contour of the zygoma bone. Alright. So option D is your correct answer. Alright, so again, students, what I'm telling you is, whenever there is such a question, please see what is being asked, go through each question one by one and try to correlate and try to rule out. Okay, in this way I'm sure you will arrive at your answer. Now coming to question number 9, which of the following is not seen in unilateral subcondylar fracture? 1. Sublingual hematoma, 2. Chin deviation, 3. Deranged occlusion, and 4. Anterior open bite. Yeah, Dental Bud Polyclinic, I just told you why do we use a Carrel-Gerard screw when there is a depressed zygoma fracture, when the body of the zygoma is depressed. What do is, Carrel-Gerard screw is a robust T-shaped screw. You engage that screw onto the zygomatic bone, engage it onto the zygomatic bone and try to lift out. That is, you try to reduce the fracture by lifting out the depressed zygoma. Okay, is it understood? Dental Bud, is the doubt clear? Yes, more answers. I see only answers from Nikesh. More answers, please. Only one screw. Dental Bud, it is only one big screw. Only one screw is engaged on the most depressed part of the zygoma, and it is used to lift out the zygoma. I hope your doubt is clear. Okay, so the question is saying unilateral subcondylar fracture. Okay, there won't be any sublingual hematoma. Okay, very good. Okay, yes, chin deviation, it's a unilateral subcondylar fracture. Yes, there will be deranged occlusion. All right, due to subcondylar fracture, there can be posterior crossbite or open bite. There won't be anterior open bite, which is seen only in bilateral condylar fractures. All right, this is seen only in bilateral condylar fractures. So the answer here would be option B, that is 1 and 4. I hope it is clear to you, Nikesh, and to everyone else also. Please answer, please interact, it is for your benefit. Okay. Before going for the exam, please do revise your condylar fractures from your notes. Okay, very good, Nikesh. Coming to question number 10, please identify the apparatus given in the images. A is urinary catheterization, B central arterial line insertion, C airway, D central venous line insertion. What would be your answer here? Okay, more answers. So yes, these are the instruments for securing the airway. Now I'm just going to zoom out. There are many things that can be covered in this image. So here, these two instruments are your laryngoscope. Okay. This is your stethoscope, we already know. Steth. These are your endotracheal tubes, your ET tubes. Okay. This is your nasopharyngeal airway. This is your oropharyngeal airway. So this quickly revises a lot of things for us. These are your laryngeal masks airways or LMAs. This is your McGill's forceps. This is your lignocaine spray and jelly. This one as well. This is your local anesthesia. Alright. This is your saline. These two ampules over here, these are your gauzes. This is your suction, and this is also your suction catheter. Alright. And these are your adhesive tapes. So this is how a intubation trolley or a airway trolley looks like. Okay. Now coming to question number 11, which of the following is used for testing visual acuity? A. Monocular vision, B. Jagger's chart, C. Hess chart, and D. prism glasses. So this again was asked in the November session, and this is a difficult question, so that's why I've picked this question so that we can revise. Please let me know the answers over here. More answers. Why are others not answering? Why are others not answering? Okay, so the answer here is Jagger's chart. Okay, Hess chart is to determine restriction in gaze. So I'll explain one by one. Your Hess chart. Okay, only 3 people are present. Okay. So your Hess chart is used to determine restriction in gazes. So Hess chart basically tests your vision in 9 directions. When we are doing a Hess assessment, we ask the patient to look straight, to look up, to look down, towards the left, towards the right, then superior lateral, inferior medial, in the inferior lateral and superior medial directions. Alright, this is your Hess chart. And with this, we can determine if there is any entrapment of any extraocular muscle that is there, especially for orbital floor fractures. Now, I have on screen the Jagger's chart and the Snellen's chart. Let us first talk about Jagger's chart. This is a Jagger's chart, this one. So in this chart, what is there is, there are a few lines written in different font sizes. Okay, so this tests your near visual acuity. So the patient is given this chart and he's asked to read the smallest font that he or she is able to read. So it is determined at what distance the patient can read the smallest font. Alright, so this tests your near visual acuity. Fine. Now this one on the other side, this is your Snellen chart. This we all must have seen very frequently in with the eye doctor in eye clinics. So this chart tests visual acuity from a distance. You're made to sit on a chair, alright, which is approximately, I think, 6 feet apart from this chart, and the doctor covers one eye, blinds out one eye, and asks you to read up till the smallest font that you can read. So Snellen's chart determines your visual acuity from a distance, and Jagger's chart determines visual acuity from a nearby area. Let's come on to the next question. Question 12. A 10-year-old child comes after road traffic accident with persistent bradycardia and hypovolemia. On CT, there is herniation of orbital contents. What is the diagnosis? A. White eye syndrome. B. Hypovolemic shock. C. Brain herniation. And D. Cardiogenic shock. Yes, the correct answer is white eye syndrome. White eye syndrome. So here the question is telling you persistent bradycardia and hypovolemia. So there's something known as oculocardiac reflex or trigeminal cardiac reflex. This is usually seen in orbital floor fractures, especially pediatrics. most commonly in pediatrics. It can be seen in adults. It can be seen in adults, but mostly it is seen in pediatric patients. Alright, so this is characterized by the triad of bradycardia, that is decreased heart rate, hypovolemia, that is decreased blood pressure, and vomiting. This is the triad. Now, two things related to this question very quickly. There's something known as a white eye syndrome and superior orbital fissure syndrome. So in white eye syndrome, the usual black eye is missing. That means circumorbital ecchymosis and circumorbital edema is missing, and there are no clinical features. So if you look at the patient, there are going to be no clinical features of an orbital floor fracture which is going to be present. And what is in a superior orbital fissure syndrome? So this is also a sequelae of trauma, especially when the contents of the superior orbital fissure are crushed, or there has been injury to the contents of superior orbital fissure. So there is ophthalmoplegia, ptosis, and pupillary dilatation. Alright, please remember there is no blindness in superior orbital fissure syndrome because the optic nerve does not pass through here. Okay, so you have to remember these two and differentiate between these two. Coming to question number 13, identify the process in the given image. A is TMJ replacement, B is distraction osteogenesis, C is Leafoot 1 osteotomy, and D is mini-plate fixation. So quickly, these the answer to this question. Yes, this is distraction osteogenesis, and this is a Leafoot 1 distraction osteogenesis. Okay, now quickly just two more visuals. So this one here is a multi-planar distraction. Okay, and this is a uniplanar distraction. Sorry, distractor device. And this is a uniplanar distractor device. Fine. So this can cause multiple planar movements in multiple planes, in two planes, and uniplanar can distract only in one direction. Okay, coming to the last question for this session. After that we wind up. Which of the following local anesthetic agent will give longest duration of pulpal anesthesia? A is mepivacaine, B prilocaine, C lidocaine, and D bupivacaine. So what would be the answer here? So the answer would be bupivacaine. Okay, bupivacaine is the answer. It is a long-acting LA, so it is not used in children. It is used for post-operative pain relief. So please remember the few important, or revise few important points regarding bupivacaine before you go for your exam. With that, we end the session. Okay, so I wish you all the very best for your INI exam. Please don't panic. Go with a calm, cool mind. Sleep well, have a good dinner, have a good breakfast. Reach your centers in time. You all have studied and prepared very well throughout the year. Alright, you all are doing well. Try to go in for maximum attempts. Read your questions carefully. Give it a good shot. And I wish you all the luck. I hope you all come out with flying colors. Thank you so much. Wish you all the very best.